Welcome back. Man, lining up so many fantastic guests today at the Chicago Midwinter booth. It's quite a buzz around here, but I'm really lucky to be sitting with one of our dear friends in our Facebook group, and just has been so supportive of the project that we've been running for 4 years now. Kandra Sellers, thank you so much for joining us today.
Thank you.
How's it going for you?
Great.
Yeah.
Busy show.
It is a good, steady crowd. In the world where a lot of meetings are not thriving,
Yeah.
this one does still seem to have what the dental community is looking for.
No doubt.
It's one of those unique places where you can come and get a lot of business done, great education. There's a ton of networking. It's almost as if the dentists just sort of take over Chicago for the weekend.
Oh, for sure.
Everywhere you go, you see a friendly face, and
everybody has a cocktail party. And
of
I'm
course.
walking to your booth, and some lady's like, "Hey, we're having drinks at our booth tomorrow. Come on by."
Okay, sign me up.
What in the world?
I know.
There's meet and
It is
greets
a special
everywhere.
kind of meeting that way. So for our guests that don't know you, don't know what your contribution is to the dental space, talk to us a little bit about that.
Well, I am a clinical hygienist that has retired and now have my own business with medical billing.
Okay.
So I help support practices in the implementation process, because I really felt after attending a two-day course 4 different times, I was
so
like, how in the world are these practices, or doctor or admin person, if they're by themselves, which was usually the case, how are they going to go back and implement this? And after being immersed like that, where do you even start? And that, to me, was the biggest gap. At that time, I was in practice management, and I thought, there is no way. And that's all I was hearing back then was, yeah, we tried that. We failed. And dentists don't like to fail.
Yeah.
And so they just shied away from it. And I really found a real downslope in practices doing it because of that.
Yeah.
They just didn't know what to do. And so that's really my niche, is really one-on-one customized implementation. I mean, I'm on the phone. I was on a call this morning from 7 to 9 with a client. That's just what it takes.
Yeah. It is so different than dental billing. There's a lot more nuance to it. And if you haven't done it for a long time, especially for doctors, when we grow up in the CDT world, we understand it, we know it. Then to make that transition into medical is challenging. And then to find support folks, either internally as your own candidates that work for you, or bringing in companies, like finding that right person that's going to make that happen.
Yeah, it is. You say it's so different. I think the biggest difference is, 1, you're out of network automatically.
Right.
2, we have a different code set. And guess what? You got to use diagnosis codes, which is coming to dental. And,
It is.
And unfortunately, nobody knows what to do with that. And the insurance carriers are holding that over people's heads, the dental insurance carriers. But
Right.
how in the world are they going to implement something that's not being taught in an educational platform? They're not. I mean, it's just ridiculous what they're expecting, because we're not ready for it.
That's right. What do you think the percentage is of offices right now that are doing medical billing, whether successful or not? Like, how much of a market has that taken over?
I would bet it's 10%.
Yeah,
maybe.
I bet you're right.
Maybe. And the longer I do this, like as a hygienist, I just don't understand why we even bother with dental benefits. I mean, at this point of the game, it's a benefit. It's a preventative benefit, and that's really about it. It doesn't cover much more than that.
Right. It's a
And
coupon
then that's
plan.
it. It's a coupon plan, and that's it. And we've got to change that mindset and just shift from that, because we've allowed it. We even have our own fee schedule that is dictated by the NDAS.
Right.
That's not a medical fee schedule. And let me tell you, the fee schedules for medical are way higher.
Yeah, for sure. And less
So-
kickback in general. If you have the diagnosis, they typically are going to provide the benefit.
Yeah.
Talk to our viewers a little bit about the types of procedure codes that, maybe procedure codes that are great starter codes that you could start to see in your practice to see how many you could be utilizing. But in general, the gamut. Where are you seeing?
I always start with simple things like exams.
Okay.
As a hygienist, if I'm doing a head and neck evaluation, cancer screening, caries risk assessment, periodontal infection, all of that is now medical. We're not talking about the teeth.
Right.
If we're just counting teeth, then you're not going to bill that to medical. But if you are doing a maxillofacial and oral cancer screening, you can now bill that to medical.
So if I'm an out-of-network doctor, which I automatically am, right, because I'm a dentist, does that cost just pass right through to the patient, or are you seeing benefit and coverage even for out-of-network services
All the
like
time.
that? Yeah.
I mean, obviously the patient has to have out-of-network benefits. So
Yeah.
you're looking for the PPO type policy.
Understood.
An HMO, EPO is not going to have out-of-network benefits. So you're just not going to bill to that.
In a robust practice that's billing medical routinely, talk about some of the procedure codes that they're billing out all day long.
So exams, fluoride varnish. We're seeing SDF covered now. There's a new code for that. And we're going to hygiene stuff, but it really starts there.
Yeah, of course.
That's where we got to diagnose. We have PANS, CTs, PAs and things like that when there's trauma. You have lateral cephs. Those are some of the diagnostic tools.
Mm-hmm.
In fact, you can get some really good coverage on CTs if you utilize that, right? Because you could bill out a CT, a tomographic study, and a PAN if your CT machine extracts a PAN.
Right.
All in the same day without any limitation.
Right.
We're dental, we got to choose between a PAN or an FMX. Like it doesn't make sense. We can bill out, so say out of hygiene, we're looking at surgical procedures, implants, bone grafts. If they pay for the implant, they'll pay for the interim prosthesis. They'll pay for the surgical stent. They'll pay for the final prosthesis if they cover the implant. We have frenectomies. We have wisdom teeth. We have sleep appliances. We have TMJ orthotics. We have Botox. And guess what? With Botox, you can bill out the Botox as well as the injections. So each poke that you do is billable. So those are just the main things. Trauma. There's so many things.
If you were looking in a magic crystal ball, do you think in a decade this is all merged together, that we're all...
Lord, I'd hope so.
I know. It would make it so much easier for...
And how did we get here?
Yeah.
How did we get to this point where the mouth is separated from the body? And I see benefits written that way as well. That even with trauma, they'll say, yeah, we don't even cover that in the mouth if it was traumatic. And I'm like, well, then why do we have insurance?
Right.
Or I've seen an oral cancer patient not have benefits. And I took that one to the state insurance commissioner and fought, and it was an exclusion in his benefit plan. I mean, I've seen some really crazy things, and I don't know how insurance carriers can get away with it.
Right.
Like that should be against the law. But until our profession stands up to that, we're not going to get any.
Yeah.
There's some insurance carriers that are discriminating against our provider type, which they can't do either. If they are willing to pay an ENT for an evaluation, they can't not pay us, as long as it's medically necessary.
Right.
So you have to know what that looks like. I think we've gotten a little slack of really understanding what we truly do, and we call it things that are not as powerful or a little bit slangy language that doesn't sound medically necessary.
Right. Well, and now we've built a whole infrastructure, and there's money and power and all that around our own separate coding system and the insurance industry. I know there's money there, particularly for one group who builds the CDT code book every year. Exactly. And a lot of power that gets played into that. And a lot of these organizations, they have the coding maintenance committee that comes together every year, coming up with big changes. And all these players are lobbying each other for new additions and stuff. So it's, we've definitely built an architecture and a...
Yeah. And I get so irritated because I know a lot of people that are on the coding committee, and they've lumped CTs in there. I'm like, why did that go to dental? Like, we're looking at other structures other than the teeth. Like, that should be medical. Now they're trying to push Botox, and I'm like, stop already. We're using Botox for the jaw joint, not the teeth. Like, just stop. Those codes should be utilized for dental in nature procedures, not medical in nature procedures.
We had this same discussion about sleep as they were pushing the sleep CDT codes.
Yes, and why?
Yeah.
Yes, it's our position to...
It's not covered. It's not a covered benefit
for it.
Yeah.
Well, and now you've exhausted the patient's entire policy for the year, and then some.
Right.
That would be like the 5-year plan.
That's right.
If you're charging $5,000 for an appliance,
right?
It doesn't make any sense at all.
Do you think the uptick for doctors embracing medical and starting to bring that into their practice is going to increase? It feels like, as a clinician, it feels like our desire to want to understand it. But you hit the nail on the head right out the gate. That 2-day weekend course, trying
You're
to
not
teach
gonna
you
get what
everything you need to know.
It's too much. And the system is very similar. The process is very similar to dental,
Right.
but it's a little different. And it's because you have different codes. And guess what? You have to have diagnosis codes, which often are not identified in a good note from the doctor. You know, it has to be, all of that has to be there so that we can identify why we did what we did and then bill it. The process is the same, but obviously your insurances are different, just like they're different on dental. You just happen to know the dental so much, so well in and out. This is different. Even my best insurance people that I train struggle with certain things. And it's like, come on, guys, it's the same thing. It's the same process. It's an RCM process. That's all it is. It's just a little different. And once you know that game for that payer, you've got it figured out. And I'm like, you're in one state. You've got this many payers. And that once you have it figured out with them, you've got it figured out. You know their game and you know what to do. Right. You know how to get a prior authorization to them. You know how to get supporting docs to them. I'm in a lot of different states and I have to do that in every state. And
I can't imagine.
It's
so
crazy.
daunting.
It can be really nuts sometimes. I mean, I just heard Jeff say that in South Carolina, they do not accept an electronic claim. And I'm like, what year are they in?
I know.
I mean, they're keeping some people employed in South Carolina. I mean, which is great, but
it slows everything down.
Oh yeah.
And I don't know, back when we were all doing paper for dental, how many claims got lost?
Exactly.
Constantly over and over again.
Yeah.
Well, I'm with you. I think the uptick is going to increase. I think either by force.
Well, we're already seeing it. I mean, if you look at dental and what they're saying, wisdom teeth, go to medical first, then come back to us. TMJ, we're seeing that sometimes too.
Okay.
We're seeing it with frenectomies. So we're seeing more of that. We're getting there. I mean, when I started my business in 2017, it was a lot worse.
Yeah.
To get, now we're starting to get recognized more and they're starting to see it. I actually had one insurance carrier call me and say, thank you for taking care of our insured patient. It was a cancer patient that needed full restoration.
That's really awesome.
And I was like, wow. Wouldn't it
Why
be nice
couldn't
if we could work this well together? Like,
Exactly.
why can't we always have
instead of us fighting each other
camaraderie? I mean,
constantly?
yeah.
Yes. Like doing what's right for the patient.
Exactly.
This should be core mission
I
one.
wish I could have recorded that.
Because I don't think any of us believe you. I think
I
I
was
was
in shock.
making this up, like that can't possibly be true. This can't be true. One of the other challenges I've heard from other doctors too is treatment planning, presentation, the cost. Like you've mentioned just understanding out of pockets and all of those things. We know dental, we feel confident pretty well when we put a piece of paper in front of a patient and say, you need this service. This is roughly how much it's going to be. How is that different? How do doctors get that support to sort of make that transition if they're doing a medical procedure?
Well, first thing I would say is like, what is it like when you go to the doctor? Do they ever discuss any fees? I mean, I just had a huge surgery in August and my bills are up to about $100,000. And I didn't get one pre-estimate on any service. And half the people that have billed me are on that bill I didn't even meet before I had surgery. So why don't, in dentistry, we've created this animal of, we tell our patient to the penny what they're going to owe. And if we go over the penny, they're ticked off at us.
Yeah.
We've created that. But it's not like that in medical. And as soon as you start talking medical to a patient, they usually understand that and they ask less questions. Like some of my providers are like, it was a game changer because really all of a sudden, like the arguments went away because they knew we were billing medical and they knew that they had to meet certain criteria for that. And it wasn't about dental anymore.
And once the
it's a
office is
shift.
confident in how to interpret that information, then they can provide guidance.
Yeah.
Right?
And so what I do with all of my clients is for every code and every payer, we track that. So we can kind of make our own sliding scale for each code per payer about what's being allowed. And that's your fee schedule.
That's so helpful. And
as the more that you do, the more claims that you get out. And I love retro billing for that because we gain a lot more knowledge. They get better at it. They see faster when we get knowledge quicker. and we can go back up to a year for most payers. It's a great way for learning and processing and gathering this information so we can build our internal fee schedule, basically, is what we're trying to do.
Absolutely.
And now
we have to do that
confident.
some actually with dental insurance providers as well. You're building those fee schedules as those
Right.
EOBs are coming through.
Yeah.
We've had a fair amount of luck with medical billing in our practice. I think we dabble enough to be dangerous. But I will tell you, for me, the biggest advantage, other than sleep, which I think is really helpful for patients, trauma is where I've really been able to help people. Because if you have an accident and you fall on a curb, especially it's winter, right? Everything's icy. We see more falls and that type of thing. And you do significant damage, to your point, your dental benefit is gone within 15 seconds of that visit.
With probably just the emergency visit to you.
Exactly. And these folks often need reconstruction. We're talking implants or crown and bridge work. Like, it's usually root canals and all kinds of things that need to be involved. And I've definitely had patients receive thousands to $10,000 worth of financial support just by engaging the medical provider or their medical insurance to say, here's our trauma. Okay, I have to tell you this. So I have spent more hours than I care to admit going through the ICD book because I am genuinely fascinated at the number of things that they have put a code to, like injury from a baseball bat being held by a secondary person, injury from a baseball bat being held by the patient, injury on a school bus missing a stair. Like, it's insanity.
I just saw one like hitting your head on the toilet, I'm not
right.
kidding.
No, there is.
And we wonder how did we get to over 72,000
correct
diagnosis codes? And the one that I use in my programs is sucked into jet engine. Like,
I've seen that
in
one.
the world, like how this obviously happens frequently.
Yeah.
Come on.
I feel
we had to come up with codes.
I was gonna say, I feel like it should then be called like the John Smith code. Like, it was him that got sucked up by the jet engine, and now he is our diagnosis code number, whatever. I feel like people should get credit for some of these crazy.
I'd like to know how many people actually survived that. Like,
I gotta think it's almost zero.
Well, if there's codes for it, people must survive, and they just must be all banged up. I don't know.
This isn't. It's so great. If you want a good, entertaining, long weekend, you're snowed in. Get Coding with Confidence is the one I killed through, and then the ICD code book.
We can go to ICD-10 data and have a heyday.
Oh yeah, I never thought there were that many things that people do to themselves. Frankly, it's pretty entertaining. Thank you so much for spending a little time with us. I really, really appreciate it. If our viewers want to find you, how do they find you and your company?
My company is Tips Medical Billing.
Okay.
So tipsmedicalbilling.com. If you go to the contact me, you'll just shoot me your information and I'll.
Awesome. And we'll have your information in the comment section below this video.
Awesome.
Thanks so much.
Thank you.